Well, is this everybody I think this is what we have for right now. I'll just introduce myself. My name is John Seip. I'm a PT up in Duluth, Minnesota. And basically, the reason why I'm here is I'm part of the student SIG for the APTA as well. But I'd work in the ER, and it's kind of a unique place to be that a lot of people have questions about because it's just not normal. um, so what I thought we would do as far as this pub night is you guys could ask a question, and then I'll do my best to answer it. And just real informal. You guys can all hear me okay? I can't hear myself in these headphones, so I have no idea what I sound like. But just a little bit about me. When I was a teenager, I broke a lot of bones. I did snowboarding, BMX, that kind of thing. So I've had broken femurs, tibias, you name it. I broke every bone in my leg. And I was going to be a PT because I wanted to get people back on their skateboards, back on the ski hill. Like sports is where it was at for me. And so all throughout PT school, I was thinking to myself, I'm going to be a sports PT and that's what I'm going to do. And it's going to be awesome. I've always had an interest in pain and that kind of thing as well. Obviously I've had plenty of it myself, but once I graduated high school, I thought, nope, not going to do PT school or college. So I joined the Marine Corps, went that route for 4 years. And then I got a degree in psychology and philosophy. And then I remembered, oh yeah, I was going to do PT. So then got into PT school a little later in life. I had my first kid, like the first year of PT school, and my second kid, the third year. And so, I mean, a little bit non-traditional, I guess. But once I was in the acute care rotation after PT school, I thought to myself, this is pretty cool because in the acute care, you kind of work. It's not like the outpatient where people are coming to you. It's more like, here's the people in the hospital, split it up amongst the team and go see who you can, do what you can. And then at the end of the day, you leave and you're done. And if you're sick or something like that, it doesn't matter. There's other people that can come in. It's not like you have patients waiting for you that need to reschedule. So the acute care environment, super fast paced, always changing, very flexible. You can work weekends, you can work weekdays. So if you need weekdays off, you can kind of move your schedule around. So I thought like it worked really, really well with having a life outside of PT, but also it was enjoyable as a PT. But the problem was for me is that my interests were still with pain and sports and spine and that kind of thing. And so after a year or two, I just was getting pretty restless. I still studied the things I was interested in, even though I was working in the acute care setting. And I would just apply those things to the acute care patients. But after a while, like I said, I was getting kind of restless. So I started looking up like outpatient jobs and that kind of thing. And I came across that people in Australia were doing PT in the ER, which is very much like treating pain and spine and some of those orthopedic things. And so I said to my boss, hey, they're doing PT in the ER in Australia, and there's a couple of hospitals here in the US that are doing it. Why aren't we? And I said, is it possible that as an acute care PT, because sometimes people get admitted to the hospital and they're admitted as an outpatient observation, so they never actually become a hospital admission, even though they're in the hospital. So and we can see those patients. So I thought, why couldn't we see them just a little bit earlier? And my boss was like, oh, yeah, that's a good point. So I just went into the ER and started doing all my documentation in the ER. And I'd said hi to the doctors. Hey, you guys can order PT, by the way. And um, so that's how it all kind of started. But it turns out it's just a really neat blend of, it's kind of like an outpatient ICU. So you take all of your outpatient patients and then you just ramp the pain up about 5 points, and then they're not quite inpatient yet, you know, so they're sort of in between. And so it turned out to be, you know, a good fit for me because it's very challenging. It fits my interests, but also like it fits my personality as far as, you know, I like to say I have an acute care personality with outpatient interests. So that's where the ER really kind of hit that niche. That's a little bit about me and kind of how I got in there. We did do a pilot study where for a month I got permission to go into the ER for mornings, and then I'd go back into the hospital, into the acute care to see patients. But that month, so I'd track every single patient I saw for that month, and just why did I see them, you know, what did I see them for, and just kind of collected all that data. And then after that, it looked like it would be sustainable financially, especially if you prevent an admission. So hospital admissions for patients are about $2,000 to $3,000 a night. So basically, in my mind, I was like, well, if I prevent one admission, that pays for me to be there for 2 weeks. So I can go home now, right? So like we kind of, a lot of you have to make a case for indirect savings to the hospital. It's not always going to be like I'm making tons of money because of my interventions, but we're saving the hospital a lot of money. So we made kind of that case. And then unfortunately the acute care was down 7 staff. So I had to wait 4 more years before being able to go into the ER full time like I have been for the last 3. So so there's a bit of patience involved and a little bit of just going in there and just doing it. So, you know, the reason why I tell this story is because, you know, as when you guys become PTs, you know, there was a part of all of you that said, you know, I want to be a PT, and you just started doing it. You started going to school and you started getting good grades. And then you said, okay, now I'm going to apply. And you just got over yourself and went and made that application and just did it. And you just got to carry that same courage into your practice. And if you're feeling like there's just something that needs to change or you want to do something, sometimes you just got to do it. And then sometimes you have to wait 4 more years before you can do it, but it starts with just starting it. So, but does anyone have any questions though? I mean, I can just ramble on for 45 minutes easily, but I want to know what I'd want to answer what you guys want to know about.
John, I have a question.
Okay.
Do you feel like you're still even this far along in the ED where they know you well and you have a good relationship with the physicians? Do you feel like you still have to advocate for them to send you orders?
Yes, that never ends, no matter what practice setting you're in. You will always have to advocate for physical therapy because we do things that other people just don't understand what we do as PTs. Like it just doesn't even like register. You know, you might say, oh, I did some manual therapy or something like that. Oh, you did a massage. No, I did joint mobilizations and got their, you know, neck or their shoulder moving. And, oh, okay, nice. You know, like they don't get it. You know, it's the things that we take for granted. The other providers, most of them have no idea what you do. And so, I'll have one doctor that will post me immediately, oh, this person's definitely a home safety problem. Like they fell at home, but they're medically pretty stable. And so it seems very clear that they're going to have some discharge problems. Like, are they going to be safe to go home? And so one doctor might post me right away for a patient like that, like before the workup's even complete, just to get me on board so we don't keep them in the ER too long. And then that same doctor might be surprised that I treat vertigo or back pain, So, or I'll see if, another doctor that'll post me for every back pain patient that comes through. But then I see that somebody, fell down and be like, hey, do you feel like they're safe to go home? Do you want me to do a gait analysis or anything like that? And they'd be like, oh, you do that? Yeah. So, that in that way, you always kind of having to like, people will hear one thing and then you just kind of add to their knowledge of what PTs do.
As kind of a follow-up to that, have you, just in your experience working in the ED, have you seen a change in general knowledge from physicians about PTs, or do you think it's about the same as when you first started?
It's definitely changed. It gets better all the time. So they use us more and more for differential. So like someone might have shoulder pain and I'll get posted because they don't know why their shoulder hurts. So I'll be kind of part of figuring out what that is. There was some research studies done about PTs as musculoskeletal experts. And the only providers that know more about musculoskeletal than a physical therapist is an orthopedic surgeon. So like, and an orthopedic doctor will be kind of right there with us. So in the ER, we're sort of like an informal orthopedic consult in a way. And so it's kind of neat because when I go back to the doctor, I'll be like, oh, I think it's this or that. And they'll ask me why. And I'll just kind of say, well, and I'll give them the whole special tests that I did or my clinical reasoning. And they're just kind of blown away because the medical students, they get about 6 weeks, maybe 2 months of musculoskeletal in their whole training, whereas we have 3 years of it.
What kind of conditions are you seeing on the daily, or is there really no typical person you see?
I'd say the home safety stuff is probably the bread and butter. So the fall risk, admit or not admit to the hospital, discharge planning, that's probably 50% right there, if not a little bit more. So sometimes, depending on a person's insurance, do you guys know what short-term rehab is? Have you guys heard of that? All right. So I'm going to tell you something right now about acute care. You can't learn it in school. I'm just going to say that right out there. Your internships will make way more sense out of a lot of the classes that you have on the acute care stuff. Right now, it's just abstract and kind of like, okay, and it's lots of words and stuff like that. So it's okay that you don't really know what a lot of this stuff is. Even if you had these classes, if you're anything like me, you probably didn't remember any of it until you actually are there. So the acute care is just one of those places where you learn it on your internship more than you learn it in the classroom. And that's just the way it is. But the way it works, a patient comes in, if they fell down at home, that's the classic example. And let's say they're 75 years old and they break a wrist and they happen to need to use a walker at baseline. So now they can't use one arm, but they're otherwise healthy. So if you admit them to the hospital, there's nothing to save their life. It's just a broken wrist. It's just pain control and they can't walk very well. So we have to decide, can that person go back home alone? Can they go back with a family member? How many stairs do they have to do? Let's say they can't go home alone. Then we might think they might need some rehab for a couple of weeks to build up their strength or build up their ability to walk or whatever it is. So then they can go back home. So sometimes we're able to send a patient, depending on their insurance, from the ER straight to a nursing home for rehab and skip the whole hospital stay. And that saves everybody tons of money. And the patient, it saves them a hospitalization. So the discharge planning, I work right next to a social worker and a case manager. That's like the biggest reason I'm in the ER as far as the hospital is concerned. But the next thing that I'll see is probably back pain, because people they get back pain and they get really scared about it. Or sometimes people that could turn into a home safety eval too, in the sense that they get back pain and they can't move. So there's a lot of evaluations where the patient was brought in on an ambulance and pulled in a stretcher and stuck in bed. And then, I get them moving again for the first time. And that's usually one of the wins for PT, because doctors and nurses are like, you walked in and the patient walked out with you. What the heck? How did that happen? And a lot of that is just because we educate them and calm their nervous system down. Because when someone is in that much pain, they feel like they're dying or that they need immediate surgery or that something is terribly wrong. But back pain can be 30 out of 10 pain and not be a severe problem. And sometimes it can be, but we're very good at figuring that out right away and not always needing an image to do that. So home safety, back pain, neck pain, I see quite a bit. Vertigo, surprisingly, I didn't think I'd see as much of it as I do, but I do a vertigo eval sometimes I'll do 2 in a day, sometimes I'll go a couple of days where there isn't one, but it's at least 2 to 5 vertigo evals a week. And so that I did not expect that there'd be that many people that had problems with dizziness. And that is another thing I will tell you guys. I was like really bad at in school was vertigo. I couldn't for the life of me figure that out. I memorized what I needed to pass the test and then dumped that info right away because it was so boring and just I couldn't keep it straight. And here I am now, the guy that they come to for complex vertigo. So again, like for me, my learning style is I would just have to self-study and learn and kind of do it and learn it and study and just learn it over time. So that's okay.
I had a question kind of off of that with like in terms of insurance too. So this summer I would see a lot of people when I was doing chart review, they would go to the emergency room for kind of like what seemed like minor things that you would normally just go see your primary care physician for or something. And I think it was because maybe they didn't have insurance to cover that. So would you see, I guess, more kind of like people assume emergency room is all traumatic, or would you see kind of a mix of like what would be or could be traumatic versus just maybe someone who doesn't have a primary care physician and they're going to the ER because they don't have insurance?
That's a really good question. A lot of people use the ER as their primary care. They don't have doctors, they don't have insurance, or they do and they just don't want to wait to go into a doctor and go through the appropriate channels. My back hurts now, I'm going into the ER. I saw a lady today who's had neck pain, and she had neck pain for 3 months. So in my mind, I'm like, well, why are you here today? You've had this for 3 months. This is clearly not an emergency. So they, posted me to go in there and check it out. And one of the cool things that we can do as PTs is we have a little more time than the doctors. So this lady, her neck pain started when her husband got diagnosed with cancer, and her husband had increasing dementia over the last summer. And so, you know, you can put 2 and 2 together. This neck pain started with a stressful event, not crash or fall or car accident. So it was all muscle tension is all it was, you know, but here she was in the ER getting a massage, trigger point release from a PT, you know. So she's there. It wasn't an emergency at all. So a lot of what I see is not an emergency, but it is what it is because that's where they go. And if she had gone to someone else, they might have started doing more imaging. And then they might have started thinking you need injections. And they started thinking you need this or you need that. But she was able to see me there. And so we sort of stopped that train wreck and said, this is muscle tension. Go get yourself a massage and manage your stress a little better and go see an outpatient PT and kind of calm her all down. So it's during the COVID, kind of when it really hit last spring and everything shut down, the ER would have like, I don't know, our ER holds up to 50 or so people. Average days are like 30 to 40 in there at one time. But during the COVID, there was like 6, 7. There was nobody in the ER for like 2 months. It was crazy because people actually only went there for an emergency. So about 75% of the people that are going to ERs are not there for true emergencies, but that's just the way it is. And so as PTs, we're perfect for working with these not true emergencies because that's where they are. And then we should be there too.
John, I have a follow-up. You started getting here, but could you talk a little more about, like the lady you saw today, what would happen? She's not a real emergency. Would she get care in the ER from somebody else if there was no PT? Or would that care be unnecessary? What would happen there?
She probably would have just gotten pain meds and told to follow up in outpatient. Some docs might have gotten her an image, which is a catch-22 because anytime somebody gets an image, you have some knowledge about what's going on, right? But then you also have some knowledge about what's going on. So a perfect example would be disc bulges. Almost 100% of people have them. You know, the difference between a person diagnosed with a bulging disc and someone who's not is an image. But when you put that word, hey, you have a disc bulge in someone's head, suddenly they start to think differently about their body and they start to pay attention to that area. And when you pay attention to something, it grows bigger in your mind, and so does the pain and disability and all the things that follows. So for some people, you need to know what's going on. And for some people like this lady, it was better for her not to get an image and just, I told her, your first step here is to just deal with the muscle tension and start with some exercises and stuff like that. If this is still bothering you in a month, then maybe follow up and get an image. But chances are, like, she just relaxed and she was able to move her neck all around just with some education, you know. So like, if she's already dealing with anxiety, adding an image to it might have, you know, you never know if it would make her anxiety worse or if it would make it better. It's rolling the dice.
I have a question, John. Are you still the only PT in the ER? And what would you say would be the ideal number / proportion of PTs to have in an ER?
There are 3 of us that mainly cover. So I actually work a 0.8, which is pretty nice. I was doing lots of stuff and being all successful, you know, and adjuncting at St. Scholastica and doing some helping at outpatient clinics and working, you know, 5 to 6 days a week. Because what I would do is I would, you know, for a semester, I'd work every single Saturday to free up the days that I was adjuncting and things like that. But then I had hip surgery. So, and that forced me to be non-weight bearing for 6 weeks and then decided to take 3 months off of work for that. And I was just like, there's just no point in working that much, you know, with life and kids and that. So, you got to let go of control of certain things at some point. And so I trust my partners, you know, so when I'm not there, they're the ones that cover, you know, the days that I'm not there, Monday through Friday mainly. And on weekends, it's a little bit different. Basically, the schedule that we started is we work basically 9 to 5:30. And we tell the physicians 9 to 5, so that gives us half hour to document or anything like that if we need to. That's Monday through Friday. I'm physically present almost the whole day. Sometimes if there's nobody coming in and time goes by, then I'll just go into the hospital and see a patient or 2 real quick and then come back down. But in order for an ER program to work, you have to be there. If you're not there, they will not use you. It's just the way it is. Things happen really quick. Like today, I had set up a concussion protocol across Essentia Health, where when they come into the ER, we take a certain baseline and give them certain education that I put together. And there was a ER in Aurora that had a concussion patient, and they called to ask, you know, what are they supposed to do with this now? And then I was there, I could take the phone call and help, you know what I mean? Like, so not everything I do is like always with a patient. You're answering doctors' questions, you're helping with processes. There's sort of like, you just have to be there in order for it to work. So Monday through Friday, I'm there as much as I possibly can. I try to be productive when, you know, seeing a patient here and there really quickly. And then Saturday and Sunday, we're not physically in the ER. So there's other PTs that are in the acute care. And if the ER needs something, they'll just call the team and somebody will come down and take it. I have to say that, you know, it's always been really humbling, and I'm very, very thankful to the team that I work with, because the kind of patients that I see in the ER is not necessarily the kind of patients everybody wants to see. So I like it, but not everybody likes it. Most people don't like it. It messes up their day and causes them to have to stay late sometimes. And sometimes in eval is you're dealing with like an anxious person and it takes forever. And so I like it, but you know, I'm really appreciative when other therapists take time out of their day on a weekend and come down and help out in the ER. So I try to just be grateful for that. But I don't know, does that answer your question, Dylan?
John, so I might actually be the only PT besides you on this call, but I'm actually starting in an ED position soon. And I was wondering if you could speak a little to the workflow of when a patient comes into the ED, like how quickly are you seeing them? Who's seeing them before you? Do you have any streamlined processes where you would actually see them a little bit faster than them going through multiple medical providers, things like that?
Okay. When in the ER, there is a big screen that has the patients coming in. And then also on my computer, you know, I have a list of all the ER patients, like everyone. And on that list, I have, so a lot of you guys have any of you guys students used Epic or EMR or any kind of, you know how you can have a patient list that has their age and their name and their height and their weight. Well, you can also add to that list reason for being in ER. What labs are they getting? You know, what are some special notes? And so I have kind of like a list that's like a partially, like a little glimpse of their chart essentially across my list. So I can look, oh, somebody's sitting in the waiting room for back pain. And then I can look at what labs they're getting. Oh, looks like they're getting a whole bunch of kidney labs. They must be thinking kidney stone. Or I could see they're here for back pain, and then I look under the little image tab and it says, oh, they're going to get an x-ray of their lumbar or an MRI of their lumbar. And these will give me hints without going into the chart of a patient that potentially may need me. So I scan that list. I'm always checking that list. I see that list all day long. And it kind of just clues me into who might need me, who's in the waiting room, what they're here for. And it'll be a little bit doctor to doctor, but especially when you're first starting, you'd have to go to the doctor who gets that patient, and you'll have to say, hey, does this person for back pain, would they benefit from seeing some physical therapy? Oh no, we're working them up for heart attack. You know, it's thoracic pain or shoulder pain or whatever, you know. So then you go, oh, okay, thanks, you know. But then sometimes what'll happen is they'll do the troponins and they'll do all the tests and they're all negative. It's not cardiac, and they'll be like, oh, it was just musculoskeletal. And then they come find you and say, hey, guess what? It's just musculoskeletal. Do you want to go see him? Okay. Some doctors, it'll boil down to relationship and, you know, how many successes you've had with a doctor. But some doctors will post me like the moment that person comes in while they're getting a workup. And so I'll be part of that. I might say, I'm going to wait for this workup before I see them. And they're like, oh, okay, that sounds good, you know. And then as soon as that CT is done, if it's negative, I can go see him right away. And then that really streamlines things, because now we're not waiting for, you know, other physicians where they do all the workup and then try to find me. Now we're making the patient wait. You know, now it's adding time to their ER stay. So yeah, as you build relationships with the physicians, they'll start posting you earlier in the workup if they're suspecting musculoskeletal, so that they aren't trying to find you after the fact. That's really helpful. Does that make sense?
Yeah, thank you. That was really helpful.
I have a question about like patient retention. How often is it that you see someone on a continuous basis versus just seeing someone once and then maybe not seeing them again?
If I see a patient again, that's bad. That means they came back. Maybe I missed something. So it's usually my goal never to see them again. That's the best case scenario. Which is another, speaking of personality, you know, I'm a kind of person that likes to help people, and I give a lot of myself and energy and thought. I like to solve the problem and think about it and put the pieces to the puzzle together. I'll sit with someone, I'll give them the time, I'll do the listening. But I have learned that because of the amount of energy I give a person, they also burn me out. So just my personality, it works really, really well to see somebody once and then that it give him a ton of energy, and that's it. We're good. If I see him more than 3 times, I can't do it anymore. Give it to a PTA. But so the ER, I just love doing evals. I'll just do evals all day long. That's just something I prefer, evals to treats any day. That's just me. Every now and then you get like cool treats. Like I remember this one 16-year-old, he fell, had a vertebral artery dissection, and he got a stroke because of it. But I brought a skateboard into inpatient rehab, and I taught him how to ollie again. So, I mean, those are the kind of cool scenarios where you see someone more than once. But back to the retention thing, I actually saw a patient. If you do, you really have to feel out who you're talking about, who your audience, are they ready to hear what you have to say? But if you really listen to somebody and you're pretty studied up on how to educate patients, you can see somebody one time and it can have a lifelong effect. If you look at some of the studies on pain science and stuff like that, they looked at, the one-time pain neuroscience education. Did it have any effect later on down the road? And they found that it does. But it has to be the right person at the right time, and you have to feel that out. An example of that was I saw this guy 3 weeks ago, and it was for back pain, and he had spasms and numbness and leg symptoms, like all of this stuff. But he had also had previous back surgeries that had given him those leg symptoms prior to coming to the ER. So when I worked with him, what I found out was that his back actually hurt above the surgery by a couple of vertebrae. And that's why it was different. And I explained to him that sometimes when you have an injury like this, it starts to wake up the stuff around it, wake up the neighbors a little bit, and flare up your old stuff. I see it all the time. So I spent some time with this guy, and it turned out he was going through a lot of stress with work and a divorce and a number of other things. And he was struggling with basic things like having fun with his kids and walking and whatnot. And so a lot of it was, in this guy's case, it was a lot. He had a tweak on his back, a legitimate minor injury, with a huge overreaction of his body. It's very, very dangerous for me to say don't worry about it unless I really, really, really know what I'm talking about, especially in the ER. But this was one of those cases where I did a thorough screen. There was no red flags. There was nothing, even though it seemed, I think if I was a new grad, I would have freaked out thinking there was red flags all over the place. But now, having seen a few things, I could rule most of that out and get to that point where it's like, okay, this guy doesn't need to worry about this pain as much as he is. So I gave him some neuroscience education, and I said, hey, can you sign this sheet so that I can go back into your chart, I can follow up, and if we ever want to write a case study or use this in research that I built to. And he's like, yeah, absolutely. So he signed it. I call him a couple of weeks later, said, hey, how are you doing? And he's like, man, you gave me just what I needed, education, not medication. And he was able to recite the stories I told him. And he talked about how his system had calmed down and he was going for walks with his kids and he was able to walk them to school and back, and how he had just a direction for the future and he felt really hopeful, and that most of the pain was gone. Even all those crazy symptoms that seemed like red flags, those were gone too. And so that's a really good example of how you can actually make a lasting change in someone's life with one visit if you do it right.
John, kind of along those lines, how often do you either like refer people directly to like mental health services, or do you think that the doctors end up doing that? Just thinking about people that you see that it turns out that this is really from like life stress or other things going on.
Yeah, the doctors, I mean, if there's mental health stuff going on and they're in the ER for that, I can think of one, like this guy, for example, you know, he was under stress and it was presenting as a musculoskeletal pain. He had an overreaction to a small injury because of his previous chronic pain that he'd already had. He's already had counselors and stuff like that. So a lot of times, you know, the people that I see that I'll identify stressors as part of their pain, it's usually not a mental health crisis level. It's more like, I'm pretty sure every one of you guys has neck pain and headaches once in a while from school. You know what I mean? But you're sort of like, yeah, I'm stressed out. There's an exam coming. But let's say you're less educated about it, you know, and you're worried about it and you think it means surgery, and you know what I mean? So then you might go to the ER for this headache or neck pain. And really it's not like an emergent level of stress. It's just normal or just a little bit above normal. You just didn't know that. I did, in my first 2 weeks in the ER, I saw a patient and for back pain, and I'm not going to go fully into this story. If you guys want to read it, it's a story I usually tell, you know, at the conferences or whatever. But do you guys know the Evidence in Motion website? Or have you ever heard of Evidence in Motion, EIM? They have like a blog. Just Google pain PT ED, a story worth reading. Basically, though, it was just a super powerful moment of treating a patient for back pain. Kind of one of those one-time things where it gave her like tons of hope. But she, you know, when I finished treating her, it was in the hallway. It was super busy, and she started crying again. And I was like, well, what's going on? And she said, before I came in here, I left my suicide note on my son's bed. And if nobody gave me anything to do about this back pain, I was done. And she'd had meds, she had image, or she'd got the image and it was negative, and that like almost sent her over. So just, that was a time where I said to the doctor, you know, she actually had suicide ideation. And so we brought in the psychologist to talk with her after my treatment. So that one I did bring someone in for. But at the end, she was not, they said she was okay. So she was okay because of what we do, which is crazy. Anybody else have any questions about ER or PT in general?
Yes, I have one. Kind of a long shot, but can you ever see yourself like going outside of the ED, perhaps like and running with EMS and working as a PT like that? I know there would be a lot of loopholes or like to get through, but just curious.
with the ambulances and all that,
Yeah.
and just seeing them in their house.
Yeah.
I'd never even thought of that, to be honest.
That's
Yeah,
a
that'd be
idea.
that's pretty cool. Like that's like an emergency home PT. So you could be a home health PT and somehow loop your way into doing EMS stuff. That'd be pretty cool. That's a great idea. Of course, they'd probably have us do all the lifting. Oh, they can't get out of bed. Hey, you do it.
Can you play the piano behind you?
Oh, no. Well, that's my boys like to play with that. I've never been that great at music. I just like to jump off stuff. That's more my thing.
What do you mean by jumping off stuff?
Like snowboarding and riding BMX bikes and mountain biking and that kind of thing. So I have, there's a skate park here in Duluth, and it's owned by, it's a Youth for Christ organization. I know religion's a touchy subject, but I do a bike church every Tuesday where they listen to me talk about life, and I mentor kids and whatnot. But we all ride the skate park for 3 hours for free every Tuesday. So I've never really got off the BMX bikes. I've been doing it for 25 years and still ride skate parks like probably 3 times a week. That's my exercise. It's just one of those things where it's just what I do.
John, my next clinical's in Duluth.
Where at?
It's at Essentia. It's in inpatient neuro.
Okay. The inpatient neuro, like as in the hospital, or at the rehabs, like the rehab section?
I think they said in the hospital.
All right. Well, I will tell you this. I love bringing students down into the ER. I have been, when I first started the ED program, I had a student in my like 3rd week of starting it. And I was like, there is no way this is going to work. Like, this is the worst thing that could possibly happen. I have to like get to know these doctors and like try to start this thing, and I have to have a student with me. This is crazy. And it was the best thing ever. Like, he made it totally better, you know, because I learned from the student as well on a few things. And this, you know, they could see a patient, I could talk to doctors. And then over time, I was just like, okay, this does work, having students down here. And so every year I've been taking students into the ER, and slowly they've been able to see more and more complex patients than I thought they would be able to see. I kind of I'm kind of in the background to make sure that we're not missing a stroke or something really bad. But one of the things that is interesting is there are PTs in the ER that do not think that students should be able to go in there because it's too risky, or new grads or any of that. And I think, to me, it's sort of the opposite, because when I had to wait 4 years before being able to do it full time, I had to study basic things like knee exams and shoulder exams and things that I was not doing in the acute care. So I was like constantly having to refresh myself on basic aspects of being a PT. And you guys are getting you're getting all of that education right now. And so, especially by the time of your 3rd internship or 3rd or 4th internship, you guys are like it's all fresh in your mind. So if someone comes in with back pain or knee pain or shoulder pain, like it's all there. You come out of school a generalist, and an EDPT is a generalist. I'm an expert at treating it, calming people down and communication. That's my biggest area of expertise, really. Differential, like making sure it's not an emergency, like making sure it's not something bad. I've caught a few tumors, I've caught some strokes. There's been several times where I've sent it back to the doctor. So my area of expertise is a generalist with a little bit higher level communication skills. So the knowledge you guys have coming out of school is like all the correct PT knowledge for working in the ED. The only thing you guys don't have is pattern recognition and some of those communication skills that comes with a couple years of working. So to me, students, it's a really good place to bring students down and make you guys feel really, really uncomfortable. It's challenging, but every student I've had has always risen.
John, if I want to work in the emergency room, are these positions available? Like, how do I do that?
That is a very, very good question. The answer to that question is yes, no. So you can work at a place like where I'm at in Duluth and get mentored on how to do it, and then pick up shifts, like when someone like me is not there, or over the weekends, and kind of build some experience. That's one way into the ER. But there's other systems that it's like rapidly growing now. And so there's other systems where they're building programs and they, don't have PTs, all the PTs they need yet to make it work. So basically, if you work at a place that already has PT in the ED, you'll probably be good to go to be there alone without having to check with people after about a year and a half or 2 years of practice. If you start your own, so you get out of school and you're going to start your own, it'll probably take 3 or 4 years to actually make the job for yourself. But if it's a goal of yours, you kind of keep those orthopedic skills and all that stuff. That's like probably how long it would take realistically. And you'll be thankful for that time. It's hard to say that now, it's hard to think about that now, but those 4 years that I had to wait before going in there, I think were somewhat necessary for me to be as effective as I am. So like that treatment I just told you about, where I had this one treatment and I could call the guy 2 weeks later and he knew the stories and stuff. Well, that's because I've told 1,000 of them and I've been able to figure out how to weave him into a story and tie his language into biomechanic and neuroscience language. And, so like those years made me be able to do effective one-time treatments better than had I started right away. It's not the most fun answer. I get that, but yeah, basically about 2 years, if you have mentorship and there's already a program, 3 to 4 if you're just going to start your own.
So John, I think we're just about hitting our hour mark, but do you guys have any last questions, or do you have any last words of wisdom for us, or anything else besides being patient for a few years?
Yeah, do what you're interested in. You know, study stuff that you're interested in. When you're with a patient, if you are interested in what you're telling them, they know that. They feel it. There's an energy there. It's effective. It works. Be yourself. And that's what landed me in this position I never even knew existed, you know? So you don't have to be the best or the smartest. You just have to be willing to be who you are and willing to do the work to be able to practice and be yourself at the same time. All right. Thanks, guys.
All right. Thank you guys for coming, and let us know if you have any feedback for us. And John, I'm sure John would be open to having anyone reach out as well if you guys have any more questions or anything. So thanks.